Okay. Oh, I gotta figure out where I'm at first. I started in the wrong spot. But anyway, I'm gonna go ahead and try to continue from where I left off today in lecture. And hopefully everybody got to see the eclipse and nobody burned the retina. That's what I'm hoping for. I did go out after class and see it a little bit. And took a few pictures that actually, some of them turned out okay. Alright, we talked about this, strains, sprains, rices, dislocations, assessment. I think that's where we are. Let me see. Yeah. Alright. So, this is about where I left off with assessments here. When we talked about assessment reveals that the client's structural shape is altered. And I told you the story about the swimmer who was swimming into the wall to hit the time pad. But the dislocated limb will usually look longer. The shoulder will slope. It'll be an obvious dislocation. All right, so the physician manipulates or reduces the joint into normal position and then immobilizes it. That's usually done. Immobilization is done with an elastic bandage, cast, or splint. So for a physician to pop an extremity back into place, the patient most likely has to have at least moderate sedation. All right, the nurse is responsible for placing the patient on a cardiac monitor, placing oxygen on the patient, and obtaining vital signs every 5 minutes while the patient is sedated. All right, make sure that the ambu bag is at the bedside related to the sedation, and most often the drug used is propafenol because it has a quick half-life. Oh, I went ahead, sorry. All right. The nurse should administer prescribed analgesics, evaluate and immobilize the injured extremity, and perform neurovascular assessments every 30 minutes for the first several hours. If the patient is discharged home, the client and family should demonstrate knowledge and skill of checking neurovascular status at least every 2 to 4 hours for the first 24 to 48 hours. This can detect any complications such as compartment syndrome. Okay, so during the neurovascular assessment, some of the things they're checking for is the patient having increased pain, decreased movement, absent pulses, increased numbness, discoloration, coolness. Again, so it's those P's, 6 P's we discussed. All right, compartment syndrome. So what is compartment syndrome? Compartment syndrome is a condition in which a structure such as a nerve or tendon is constricted to a confined place affecting nerve innervation. So this leads to decreased sensation and movement, also known as, hopefully you guys will get your book and look it up, but the answer is palsy, also known as palsy. So if compartment syndrome occurs in an upper extremity, it may lead to what's called Volkmann's contracture, leaves the client with a claw-like deformity. The client's unable to extend his or her fingers and complains of pain, especially when trying to stretch out the hand. Okay? There is emergency treatment for compartment syndrome to prevent loss of or permanent injury to the extremity. I need you guys hopefully to look that up and find out that answer. The answer is a fasciotomy. All right, fasciotomy is a limb-saving procedure where the fascia, or the layer of tissue, is cut to relieve that pressure on the nerves. All right, so here's you some pictures of compartment syndrome. You can see how greatly swollen this is from this one. You can see the blue discoloration. Okay, clearly we've got issues going on. This over here is showing you a picture of a medial fasciotomy incision through the fascia, exposing the superficial posterior compartment. But what that does is relieve the pressure on those nerves. Okay. All right, upper and lower extremity injuries. Specific injuries to the upper and lower extremities are things like tendinitis or tennis elbow. Tendinitis is the inflammation of a tendon. Okay, let me back up. Tendinitis is not tennis elbow. I misspoke, so I'm going to back up. Tendinitis is just the inflammation of a tendon caused by overuse. Now, epicondylitis is another word for tennis elbow. Epicondylitis is the medical term for tennis elbow. All right, so epicondylitis is when an injury occurs to the tendons of the medial or lateral radial and ulnar epicondyles, sustain damage from excessive pronation and supination of the forearm, like when you're playing tennis and you're over, up, over, up, over, up. Okay? The patient has pain in the forearm and a weak grasp. You can also have golfer's elbow. Can't, off the top of my head, remember the medical term for that one. Just try to look it up. The golfer's elbow is going to be on the epicondylitis, or tennis elbow is when you have this issue in the tendon out here. And golfer's elbow, gotta get my camera situated, is when you have the pain with the tendon on the inside. And that's what I have, is what they're calling golfer's elbow, which is an inflammation of the tendon on the inside here. All right, a ganglion cyst. Probably many of you have heard of this or seen people that have had a ganglion cyst. It's a cystic mass that develops near a tendon. It's formed through defects in the tendon sheath or joint capsule. The patient will have pain at the affected area. Most commonly, they're found in the wrist, and you'll see just this little, I don't know, elevation, kind of like my bone here, but it's not the bone. It's an actual just encapsulation of fluid in there. And there's a video posted, I think, about it, about the ganglion cyst. Treatment for ganglion cyst used to be, some of you may know this, they would slam a Bible down on their, or a heavy book. The Bible is what most people are using as a heavy book. They would slam a heavy book down on that cyst to pop the cyst. You can also have the cyst withdraw the fluid, aspirated, have the cyst aspirated. All right. Treatment still for epicondylitis and the ganglion cyst are ice, heat, NSAIDs, steroids, analgesics, and rest, and sometimes surgery is required. So my father-in-law is actually going in tomorrow, for his second surgery for tendonitis in the elbow. He had it done on one arm, and now he's going to have the other arm done. All right, carpal tunnel syndrome is different. So carpal tunnel syndrome results from repetitive wrist motion that traumatizes the tendon sheath or ligaments in the carpal canal, produces swelling that compresses the median nerve against the carpal ligament. So the key with carpal tunnel syndrome is that it's a nerve injury more than a tendon injury. Clients can complain of pain to one or both hands, radiating up the forearm or the shoulder. Pain is often worse at night and early in the morning. Sensation can be lost or reduced in digits 1 through 4 with carpal tunnel syndrome. All right. I have multiple family members that work at Toyota, and repetitive motion that they constantly do usually, and it does happen a lot with factory workers who do the same repetitive motion over and over again, and they end up having to have they end up with carpal tunnel syndrome and potentially surgery. All right. Treatment includes splinting to rest the hands and wrists, use of NSAIDs, periodic injections of corticosteroid preparation, and or surgery to release the pressure of the ligament on the median nerve. Okay. What I have is a pinched nerve, this pinched nerve up here in my elbow. So it's called cubital tunnel syndrome because it's in the antecubital space. Your elbow is considered antecubital space. All right. Diagnostic testing for carpal tunnel syndrome. Tinel sign and Phelan sign. I have YouTube videos posted on this. It's also listed in the book, so be sure that you read about it. Tinel sign detects the irritated nerves. If the patient has carpal tunnel, they have numbness and tingling when you lightly tap over the nerve. So when I go to PT every week, that's one of the things they test is Tinel. They tap around that nerve, and it shoots this pain down my fingers. Phelan sign is when the patient puts their hands together for 30 to 60 seconds, and then the examiner applies force inwards. Patients with carpal tunnel will experience numbness or tingling with that. Okay? So those are both in the book, and I have videos posted on it. Rotator cuff tear. It occurs from overuse or irritation of the shoulder joint or traumatic injury. Diagnosis is based upon exam. The patient will experience pain with movement, especially lifting their arm over their head. So, like I said, particularly pain over their head. 3, severity of injury is determined by X-ray and MRI. So, the diagnosis, again, is based upon physical examination. They have the 3 key signs and symptoms really are Pain, hold on, I can't even read my own writing. Pain. Okay, ignore what I said because I can't read my writing. Oh, now I see what I was writing. Okay, so diagnostics is based upon physical examination of the patient, particularly when they lift their arm up over their head, they're going to have a lot of severe pain. If the pain runs down past the elbow, it may not be a rotator cuff tear. Okay. All right. Treatment includes NSAIDs, and they're often advised to rest. Patients are unable to sleep on the affected side. If you have a rotator cuff tear on the right, you can't sleep on your right side. The pain is much worse at night when you have rotator cuff tear. If surgery is needed, the client will need to immobilize the shoulder for several days to weeks and then needs physical therapy. Clients should have full recovery within 6 to 12 months. So I've been doing a lot of physical therapy for my hands and elbow, and always seems like I'm always in therapy with somebody who's had rotator cuff surgery and is doing physical therapy from recovering from a rotator cuff tear. All right, ligament and meniscal injuries occur as a result of a traumatic injury, such as your ACL and MCL. That's what you hear the most of, ACL tears or MCL tears, your anterior cruciate ligament and your medial cruciate ligament. All right, these occur when the client is standing firmly and receives a blow or twist in a different direction while hyperextending the knee. The menisci become injured, disrupting the stability of the leg when flexed or extended. Clients with meniscal injuries will complain that their knee gave out or locked up, and they'll complain that they heard a popping sound from the cartilage moving. All right, treatment includes NSAIDs and ice for the first 48 hours. If the meniscus is in fact torn, the surgeon does need to perform a meniscectomy, to remove the damaged cartilage. Recovery time is anywhere from 3 to 12 months, depending on the severity of the injury. And then you do a gradual introduction of activity to prevent further injury. So lots of athletes have ACL and MCL tears where they are running on the basketball court, running down the soccer field, and make a sudden turn, a sudden movement, or someone runs into them once they've already planted their leg, and it will cause a tear. Now, they can come back from that. They can recover. Especially younger children, teenagers and things, but it's really, really hard. It's, when people go down with meniscal tears or ACLs, they go down and they are in a lot of pain, and it's immediate pain. All right. Fractures. Moving on to fractures. Well, there it is. Fractures. Lost my place in my notes. This is a very obvious fracture here. All right, a fracture is a break in the continuity of the bone. Blood seeps into the area of the break, a clot is formed, and over time these cells form a callus which stabilizes the bone, but full bone remodeling can take up to 12 months. So how is this information important to client education? Okay, one of the biggest things is the fact that they may take your cast off in 6 weeks and tell you you're good to go, but you truly are not. You really need to put on splint or some type of stabilizer when you return to vigorous activity, because it takes up to 12 months for those to truly heal. Okay, so you're not really back to normal. If you don't do some type of stabilization, even if you do, your risk of refracture is very high in that first 12 months. Whoops, sorry. All right, so let's discuss different types of fractures. This is all in your book, but you do need to understand this and know the difference. You're going to have to know these different types of fractures. Okay, so an avulsion fracture is something I did talk a little bit about today. A fragment of the bone is pulled away by a ligament or tendon. Comminuted fracture is when the bone is splintered into several pieces. A compound fracture is when damage involves the skin. So that happened to the basketball player not that long ago. I think it was U of L's we were talking about. Basketball player came down and literally had a compound fracture where the bone came right through the skin. Now, when the bone comes through the skin, what other complication are we going to have? On top of the fact that we have a really bad break, a really gross break, we've now broken the skin with the bone. So now we have increased risk for infection. Okay. Where am I? Compression fractures. Compression fractures when the bone is compressed. So these oftentimes are vertebral fractures. You jump up and you come back down real hard. That can be a compression fracture, or from trauma. Green stick fracture. These are pediatric fractures. A green stick fracture. It's where one side of the bone is broken and the other side is just bent. It's not a break through and through. And that's because pediatric bones are much more pliable. And so they may not break through and through. So they may have what's called this green stick fracture. An oblique fracture occurs at an angle across the bone. So it's not a straight across break. It's at an angle. Pathologic fracture is a diseased bone. So it's a fracture that occurs due to something such as osteoporosis, decreased bone density, things like that. Your spiral fracture is actually a fracture that occurs from a twisting motion. So it is very commonly monitored if that spiral fractures occur in children for potential abuse, because a spiral fracture is easy to get from twisting like this. Now, it can also happen because you plant your foot and twist, and you can get a spiral fracture on your own. However, that is one of the things that's looked into for pediatric, in particular, younger kids or whatever, if they have a spiral fracture for abuse. Transverse fracture is a fracture that's straight across the bone. And then your depressed fracture is a downward fracture. That would be like a skull fracture if you got hit in the head with something and you fractured your skull and you'll have a depression in there. That would be a depressed fracture. Okay, one other fracture that I didn't discuss was a stress fracture. The stress fracture is just a crack, literally a tiny little crack in the bone from overuse. It is often not evident on x-ray for a few weeks, and it's usually seen in the lower extremities of athletes, high-impact sports, basketball, soccer, track, things like that, and they will very commonly have stress fractures. Fractures usually occur from a direct blow or force, but sometimes a fracture can actually occur just from a strong muscle contraction. The muscles can actually contract in opposite forces and actually cause the fracture itself. For instance, in seizures, really bad seizures, that can happen. Sometimes bone infections, such as osteomyelitis, which we talked about earlier, bone tumors, and we talked about decreased bone density with pathologic fractures can cause fractures, bone fractures. So again, be sure that you understand all of these different types of fractures. If I were to give you an example of something that happened, and you could describe which fracture it was. All right, complications from fractures are compartment syndrome, which we've already talked about. The tissue perfusion is compromised related to swelling. You'd have to elevate the extremity, do neurovascular checks, apply ice. The signs and symptoms would be pain that's unrelieved by medication. Thromboembolism is another big complication with fractures. Can lead to a pulmonary embolism, which results in the patient being very anxious and having decreased saturations, O2 saturations. All right, so sometimes patients will be put on low-dose heparin. A fat embolism is another thing that is most often seen after long bone fractures. So you'll have to go back to the very first lecture to figure out about the long bones, or to refresh your memory on long bones. But fat embolisms are most often seen after long bone fractures or crushing injuries. You need to provide early immobilization, respiratory support such as turn, cough, and deep breathe. Monitor the patient for respiratory distress. Signs and symptoms of respiratory distress, if they have a fat embolism, would be things like increased respiratory rate, cyanosis, grunting, confusion, retractions, and that's usually going to be seen within the first 48 to 72 hours of the fracture. Okay, so it's pretty quick, 48 to 72 hours. Delayed healing can be a complication with any type of fracture. Can lead to non-union of the bones or malunion of the bones. So the bones may go back together, but they may not be aligned correctly. Okay, infection. Chances increase with the compound fracture. Application of skeletal traction or surgical procedures. All three of those are obviously going to increase your risk for infection. You're going to use aseptic technique. Osteomyelitis is an infection in the bone. Sorry. Avascular necrosis can occur, which we already discussed. Was avascular necrosis is death of the bone from insufficient blood supply. Signs and symptoms would be pain, unable to use the affected limb, and avascular necrosis is most commonly occurs if in fractures of the femoral head. Okay. You can see table 62.1 for complications of fractures on page 1077. All right, signs and symptoms of a fracture, which seems pretty obvious. However, it is not so obvious all the time. Fracture is not so obvious. Pain is obviously the most common symptom. Loss of function, the patient will no longer be able to use that extremity. There may be deformity if it looks in a very unusual position. I know last season, maybe it was season 4 last, I don't know, the time seems to fly. I wasn't there, but at one of the kids' soccer games, someone broke their arm, and I'm thinking, how do you know it was broken? Because, you know, how do you just know it's broken besides there might be a problem? And the husband said, oh, it was definitely broken. It was severe deformity, just like the picture I showed you in the very beginning. False motion is another symptom of a fracture. So if you have unusual movement of an area that shouldn't be moving that way, he's probably got a fracture. Where am I here? Crepitus. Hopefully you guys remember that crepitus is that popping sound, but grating sound of bone ends moving over each other. Can also be caused by air trapped in the soft tissue. Edema is a very common symptom of fractures. I think I told you all before that when we talked about casting, oftentimes people who have a fracture may not get casted right away. They usually will have to wait, 24, 48 hours, even 72 hours for the swelling to go down before they can truly cast for the fracture. Spasms are a symptom of fractures caused by the muscles near the fracture contracting. If the long bone is involved, then these spasms may cause shortening of the limb. All right, one or more x-ray views can determine if the fracture is present and the severity of the fracture. In some cases, CTs or MRIs have to be necessary. Stress fractures won't be evident for a few weeks. So I can't remember, I'm sure I've told you guys at some point, but several years back I had a crushing injury. So we were building our house, and anyway, we were trying to put in a new cable outlet. So we would have a couple of cable outlets in the room, and they already had the drywall stacked against the wall, the big pile of sheetrock. So we were trying to lean it forward a little bit. So I was there with my husband and my father-in-law, and we were like, all right, let's see if we can even move the sheetrock. So they rocked it forward, and it started falling, and they were smart enough to get out of the way. And all I saw were dollar signs, thinking, oh my God, how much is that going to cost when all that sheetrock breaks? So I tried to push it back up, and obviously I could not hold that stack up. So it fell on my leg and crushed my bones and my feet, and actually broke the floorboard. So I was glad that I was on the second floor. If I'd been on a first floor slab, I would have crushed everything. But we were on the second floor and happened to be between floor joists. So my leg literally crushed the floor. The whole floor had to be replaced. And, but my foot swelled up real big. It was a big hoopla. But anyway, the whole point of that is I went to the ER finally. It was on a Sunday, so I wasn't going on Sunday. I did go the next day, and they took x-rays and said, oh, I don't think anything's broken. I think it's okay. And I'm thinking, there's no way everything's okay. Anyway, the radiologist read it, and they called back later in the day and said, oh, we think you need to go follow up, and you may actually have something going on that we can't really tell exactly. Ended up having to have an MRI. And when they did the MRI, they could see that I had numerous microfractures throughout my foot, which they couldn't do anything about. There was no surgery they could do. That's why I still have a lot of problems with my feet. All right. Goal of treatment. Goal of treatment is to reestablish functional continuity of the bone. Treatment is discussed in chapter 61. Those are things like traction, reduction, internal fixation, external fixation, casting. Okay. Nursing management includes assessing for neurovascular and systemic complications, administering analgesics, providing comfort measures, assisting with ADLs, preventing infection, promoting physical mobility and skin integrity, and preventing constipation, which we talked about all that. Wow, you're going to get the constipation. All right, fractured femur is most often the result of a trauma. High risk. A fractured femur has a severely high risk for bleeding. The human body has 5 liters of 5 liters of blood, and you can lose up to 1,500 to 3,000. So 5 liters is 500 milliliters. You can lose 1,500 to 3,000 milliliters with a blood with a fractured femur. Okay, so it's serious. You got to be very cautious, meticulous, and monitoring them very closely. All right, the client will have severe pain, swelling, and ecchymosis, most often treated with some form of traction. Client will be confined to bed. The nurse implements measures to prevent complications of immobility and inactivity. We're going to need to do pen care. We're going to need to talk about the diet, which we've already talked about. We're going to have to take respiratory measures to prevent respiratory complications from immobilization. We're going to have to do measures to prevent constipation from immobilization. Okay? So all things we've already discussed. All right, here's a picture of a femur fracture. It's pretty bad. All right. Fractured hip affects the proximal end of the femur. Results from falls and affects older adults with osteoporosis mainly. I'm going to tell you a story real quick while I'm thinking about it. When my sister's husband, so my brother-in-law's mom, they came up here to pack up her stuff, and she was moving down to South Carolina to live with my sister and brother-in-law. And I think they'd gotten most everything packed up and everything. Anyway, she happened to just be in the garage, and I don't even know why, but she just fell in the garage. That fall caused a fractured femur, and oh my gosh, it was serious, and she lost a lot of blood with it. And so anyway, they were supposed to be down, taking her back to South Carolina, and they couldn't do that obviously because she had to stay in the hospital here. It was quite a while before she could travel even down to South Carolina. All right, that's just a little story for you. Let me find my notes. Hip fractures often fracture the femoral neck. We just said that. The client client will complain of severe pain with movement of the injured extremity. The injured extremity will be shortened. So the affected leg will be shortened and externally rotated. So shortened and abducted outside. Why does that occur? Okay, hopefully you've thought about it or looked it up, but that's going to occur from the muscle spasms and the discontinuity of the bone. The muscle spasms and discontinuity of the bone cause the shortening of the leg and external rotation. All right, a large amount of blood loss may accompany the fracture, leading to hypovolemic shock. Hip fractures are prone to non-union, so the bone's not coming back together. And avascular necrosis, death of the bone. All right, therefore, hemiarthroplasty is often performed. What is a hemiarthroplasty? Again, hopefully you'll take time to pause this video and look up these things. You'll get a lot more out of it. But a hemiarthroplasty is where half of the hip joint is prosthetic. So they're not replacing the ball and the socket, but they're just doing half, which is usually the ball in this case, of a prosthetic. All right, the bone then heals around the metallic device, and the bone will be united. Nursing management includes that of a post-op client confined to bed. So all those things we just talked about a few minutes ago. Review Chapter 61 for proper body alignment for client with the hip replacement. And that has to do with the things we talked about today that you all said, could you please stop talking numbers with the 90-degree angle thing, all right? Proper alignment for hip replacement. We're going to go over it again. It's that important. Sit the patient with the hip angle greater than 90 degrees. Why do you do that? Because anything less than 90 degrees can cause dislocation. Again, I hope y'all wrote down the whole less than greater than thing so you understand this concept. All right, you're going to implement measures to prevent skin breakdown. You're going to clean the patient when they're soiled, use barrier creams, turn every 2 hours with an abductor pillow. We're going to try to prevent wound infections. So we're monitoring the wound in the surgical site. We're trying to prevent pneumonia, so we're encouraging turning, deep breathing, Respirex. We are going to try to prevent constipation, so we're increasing fiber, increasing water intake. We're going to try to prevent urinary retention, so we may have a Foley catheter in for a while. And we're going to try to prevent muscle atrophy and contractures, so we're trying to get the patient up and walking and moving as quickly as possible. Complications from hip fractures can often lead to death for the elderly patient, not because of the fracture itself, but usually because of pneumonia or a pulmonary embolism related to the immobility related to the fracture. Okay? Here's your picture of a hip fracture there. Whew. All right, that's through 62. Now I'm going to start 63, and literally I'm really not doing very much of it, just the first little section here of 63, but I want to get started on it because I really don't have that much more time with you guys. All right, 63, caring for clients with ortho and connective tissue disorders. So the first thing is inflammatory disorders. Caring for clients with orthopedic and connective tissue disorders. Inflammatory disorders such as arthritis and rheumatoid disorders. So arthritis is a general condition characterized by inflammation and degeneration of a joint. So I think I've told you all that's part of why I wear that splint on my thumb is because I have arthritis of that joint. Rheumatic disorders. There's more than 100 types of rheumatic disorders. The most common are orthopedic issues. It's one of the most common orthopedic issues, sorry. Rheumatoid arthritis is a systemic inflammatory disorder of connective tissue and joints characterized by chronicity, remissions, and exacerbations. They have a very high potential for disability with rheumatoid arthritis. It is believed to be an autoimmune disorder, a very strong genetic association with the HLA, the human leukocyte antigen. It most often affects women ages 20 to 40, but equalizes as adults age. Okay. RA affects the small joints early in the disease and larger joints later in the disease process. Okay. Be sure you see figure 63.1. Tells you a little bit about it. Maybe I'm going to go. All right, there we go. Inflammatory cycle. Synovitis increases. All right, synovitis increases as congestion and edema develop in the synovial membrane and joint capsule. Synovial tissue experiences reactive hyperplasia, which is an enlargement of the tissue. The redness and warmth occur due to vasodilation and increased blood supply. Pannus is destructive vascular granulation tissue formation occurs. So pannus formation occurs, but the pannus destroys the cartilage, joint capsule, and bone and forms between joint margins, decreasing joint mobility, leading to ankylosis. If you hopefully recall, the ankylosis is immobility of a joint. The disease will progress, causing further inflammation and structural changes. All right, assessment. Onset of symptoms is acute, and joint involvement is usually bilateral and symmetric. Localized symptoms include joint pain, swelling and warmth, erythema, limited mobility or stiffness. As the disease progresses, clients will often experience anorexia, weight loss, fatigue, malaise. Other systemic features include vasculitis. If you don't know what that is, look it up. Neuropathy, scleritis, pericarditis, splenomegaly, and Sjögren's syndrome. Okay. Decreased tolerance for stress and environmental changes can occur. Rheumatoid nodules may appear. These are evident over bony prominences, are not non-tender and movable. I'm going to move my sure around here. Later stages include muscle wasting around the affected joints, accentuating the appearance of swelling. The proximal finger joints swell the most, showing the classic RA deformities. Okay. So the choices, there was proximal or distal. It's the proximal finger joints swell the most, showing the classic RA deformities. All right, swan neck deformity. This is in the book if you don't catch what I'm saying, or you can play it back. The swan neck deformity is hyperextension of the proximal interphalangeal joint, and really hope y'all can remember proximal and distal. Some of you didn't do so great on that test question. It was about proximal and distal to the traumatic injury. So I'm not sure if didn't get the test question, or if you didn't understand proximal and distal. So swan neck deformity is a hyperextension of the proximal interphalangeal joint with fixed flexion of the distal interphalangeal joint. I'm going to show you a picture in a minute. Boutonniere's deformity is a persistent flexion of the proximal interphalangeal joint with hyperextension of the distal interphalangeal joint. And ulnar deviation is when the fingers deviate or are aimed more laterally towards the ulna. Okay? So this is boutonniere deformity. Boutonniere was a flexion of the proximal, where's my mouse? Flexion of the proximal and hyperextension of the distal. Swan neck deformity was hyperextension of the proximal, right here. Oh, where did my mouse go again? Hyperextension of the proximal and flexion in the distal. DIP, that's distal interphalangeal. Proximal is PIP, proximal interphalangeal. All right, then ulnar deviation. This is the radius, this is the ulna bone, and this is when the joints drift towards the ulna. Okay. All right, at this stage in the disease, clients have chronic pain that is worse when? It's going to be worse in the morning, right after they've slept. Symptoms may resolve suddenly. The client will be free from joint inflammation, redness, pain, and fever. However, symptoms will return. Okay, inflammation will lead to more joint damage followed by another remission. So it's this constant exacerbation and remission. Okay, I'm going to stop there. We'll go on with RA in class on Monday. So for the exam next Monday, everything I went over in class today and everything I've just lectured on will be considered for test questions for Monday the 28th exam. All right, let me know if you have any questions.